Presenting of a case of the patient, Mrs. Pavitra, age 24. She has studied till second PUC, and her occupation, she's not working, she's a housewife, and she's hailing from Kengeri, Upanagara, Bangalore. Her religion is Hindu. The date of admission is 21st January, and the date of examination is 23rd January. Family details. The type of family, it's a joint family. The composition of family, the number of members in the family are 5. Head of the family is Manoj Kumar. The details, further details. Name of the patient Pavitra. She's the wife in relation to the head of the family. Her age is 24. Female. Studied till second PUC. Her marital status is married. She's a homemaker. She's not working. And then Manoj Kumar is the head of the family. Age 30. And he's educated till SSLC. His marital status married. His occupation is he's a carpenter, and his income is 15,000. Indi Malavati, she's the mother of the Manoj Kumar, and her age is 55, and she's been educated till 8th grade.
Hello, sir. Is it audible, sir?
It is audible.
Volume,
Okay.
audible, but volume is low, I think.
Yeah,
Yes.
volume is low. You can use.
Nisarga, you are there, right? Hello?
Yes, ma'am, I can hear you.
Yeah, speak a bit louder, okay?
Okay, ma'am.
Yeah.
The son is Dhanush, age 3, and he's 3 years old. And the remarks, he's immunized till date. And the fifth member is Padmavati. She's the grandmother in relation to the head of the family. Her age is 77 years, and she is widowed, and she's a homemaker. And in the remarks, she is hypertensive. Total monthly income of the family from all sources is 15,000. The per capita income is 3,000, and they're above poverty line. The socioeconomic status is lower middle by modified Kupaswamy scale. The health services around them, there's an Anganwadi and a primary health center. Social institutions, there's a school, there's a bank. Card holder, she has a Thai card, and there's a widow pension for the mother and the grandmother of Manoj Kumar, rupees 600 and rupees 1,000. Shall I continue, sir?
Yeah, continue. Any important volume? Somebody is telling volume is very low.
Sorry, sir, could you repeat?
Volume is very low.
Volume. I'm sorry, sir, I'm not able to increase the volume. I'll try speaking loudly.
If you are having earphone, it's better, I feel.
Sorry, sir.
If you're having earphone or headphones.
I tried with the headphones, sir, previously. It was not audible. So I'm trying the earphones now.
Okay. Yeah. Okay, then you can continue.
Can I continue, sir?
Yeah. If you
Continue.
Medical history. Mrs. Pavitra presented with 9 months of amenorrhea and is admitted for safe confinement. Obstetric history. Her obstetric score is G2 P1 L1. History of the previous pregnancy. 3 months after marriage, spontaneous conception confirmed by UPT after 1 month. And there was a history of polyhydramnios in the first pregnancy. It was a full-term vaginal delivery, a male child, weighed 3.1 kg and cried immediately. The child was breastfed for 1 year, and complementary feeds were introduced during 6 months, and child is immunized till date. And the interpregnancy interval between the first and second pregnancy is 1 year, 11 months, and there was no use of contraceptives in between. History of present pregnancy. Spontaneous conception.
Nisarga?
Diagnosed by UPT at 1 month and is confirmed in the hospital first trimester. There was presence of history of and vomiting, no history of increased frequency of micturition, and there was history of folic acid intake. There's no history of fever with rashes. There was no exposure to radiation or any drug intake. There's no history of bleeding PV. Dating scan was done at 1 month and the results were found to be normal. ND scan was also done and the results were normal. Routine investigation of the blood and urine was normal.
Okay.
Second trimester.
Okay,
Nisarga.
Nisarga,
Yes, sir.
Abhilash.
just come to the previous slide now. Yeah,
Yes, sir.
previous slide.
Yes, sir.
Okay, the format differs in OBG slightly. Okay,
Yes, sir.
we usually mention in preliminary details we add obstetric score and LMP, EDD. Okay,
Okay, sir.
so that
Yeah.
we may know the period of gestation clearly, so that our we know what case we are sailing through and what is our end result. Okay, so we have to know the period of gestation. Roughly, do you know what is the period of gestation?
Yes, sir. It is 37 weeks, some 6 days. So we can say it is 38 weeks.
Around 38 weeks. So why
Yes.
she's admitted for safe confinement? Any idea? Usually we admit at 40 weeks, right?
Uh, yes, sir. But when we asked her, she said that she came just 1 week early.
She came with,
She just came early, sir.
or maybe she's staying far away, so she came early. Is it? There is no
Sorry, sir.
transport facility or something. Usually we don't admit at 38 weeks unless some risk factors are there, or some risk factor should be there, or patient is not able to, like, traveling facility is not there. Then only. Okay.
Okay, sir.
Yeah.
Okay.
Nisarga.
Then
Continue, Abhilash.
in history of present pregnancy, we usually begin with the why she came. No, that complaints will elaborate first. Then we go for the history of previous pregnancy and your history of present pregnancy. Okay.
Okay, sir.
So in third trimester, when she presents, whether she appreciates fetal movements well, whether there is any pain abdomen, leak PV, bleed PV are important. Okay.
Okay, sir.
And what else you'll add in present situation? What other history you will ask
Um,
in the present situation?
in present situation.
So any history of contact with COVID patients or any history of fever, breathlessness, whether she's a healthcare worker, all those things needs to be added. Okay.
Okay, sir.
People also should be aware of, I think, COVID-related problems, the pandemic. Okay.
Okay, sir.
Yeah, Nisarga, as
Will
Abhilash. Yeah, Abhilash, ಒಂದೇ ನಿಮಿಷ.
yeah. I said.
As Abhilash sir told, you have to add the obstetric index with the LMP and EDD, and usually we start with present pregnancy only. We don't talk about first about history of previous pregnancy.
Okay, sir.
Okay, that should become as a previous history pregnancy as a past history.
Okay, sir.
Okay, yeah, Abhilash, you can.
Okay. Polyhydramnios, any cause for polyhydramnios?
No, sir. She did not mention any cause.
What's the commonest cause for polyhydramnios?
Sorry, sir. Could you repeat?
What is the commonest cause for polyhydramnios?
Commonest cause, sir. Not sure, sir.
Okay. GDM is one of the causes which we should rule out, but commonest cause is idiopathic. Reason is not known. Okay. Idiopathic is common. Apart from that, other causes being GDM, medical disorders in mother, or in the fetus, if any renal disorders are there, then polyhydramnios, or any GI anomalies. Okay. We have to rule out anomalies as well. Okay.
Okay, sir.
Okay. Can you just define gravida, para?
Yes, sir. Gravida is defined as a status of a pregnancy, past and present, and the outcome is not known. Para is any previous pregnancy which has crossed the period of viability.
Yes. Okay. Next you go. Trimester wise history.
Okay, sir. First trimester, there was.
Okay.
There
What
was
do you?
history of-
How will you comment on the interpregnancy interval? Is it adequate? Why contraception was not used?
Sir, could you repeat once again?
What is your comment on interpregnancy interval?
Yes, sir. The normal, like the minimum amount, like the period of interpregnancy interval should be 3 years. In this present, it's like approximately 2 years. So it's
Okay. So why contraception was not advised?
um,
First pregnancy, what are the contraceptive? options available postnatal?
We can give them an IUD.
When?
It can be given second day after postpartum.
Within 2 days, that is postpartum IUCD, or if
We can give even
the time period is
pills.
gone, then
Combined pills can be given.
combined pills are not given in postnatal period.
Oh, okay. So injectables can be given. So MPA is
Injectable,
much
so
safer.
Antara MDPA injections we can use. That is after how many months you start?
After 6 months.
Started after 6 weeks. Okay.
Okay, 6 weeks.
Okay. Fine. You have to read about contraception. Okay. It's important. Then your first trimester history. Why you asked for nausea and vomiting?
Nausea vomiting because there's the increase in the beta HCG hormone levels, which is causing nausea vomiting.
What is hyperemesis?
Hyperemesis is then there is increased nausea vomiting, and it's even causing an effect in her daily functioning, and she's not able to do her work.
What are the causes?
Causes, there could be if there is increased starvation, then
Pregnancy itself can cause. Other than that, we have to rule out molar pregnancy and multiple pregnancy. Okay. Folic acid, what is the dose?
Folic acid, we give 500 microgram.
500 microgram for? Why folic acid is given?
100 tablets are given in the first trimester.
No, why folic acid is being given?
Folic acid is given to prevent neural tube defects.
For neural tube defect prevention, it is preconception and antenatal or first trimester folic acid of 4 mg. Okay, 4 milligrams.
Okay.
Whereas 400 micrograms is given for anemia prevention. Okay. Okay. 4 mg is for your neural tube defect prevention. Also, if there is a history of previous neural tube defects or family history of neural tube defects, or if patient is on anti-epileptic drugs or any drugs which causes folic acid deficiency, nowadays routinely we give as preventive measures. So 4 mg is given. Okay, 400 microgram for anemia prevention is the recommendation. Okay, increased frequency of micturition, why you asked?
Because now the uterus is growing and there can be irritation.
Yeah, it can be irritating.
This change in the.
So it can be a normal physiological phenomenon, right? Increased frequency.
Yes, sir.
Okay, go next. Next.
Yeah, just 1 minute. Nisarga,
yes,
so what is the ideal interpregnancy interval we expect?
3 years.
3 years. And you told breastfeed for 1 year. What is exclusive breastfeeding?
Exclusively breastfeeding is the mother should start and she may continue for 1 year, 1.5 years, and no other. There shouldn't be any, at least in the first 6 months, there shouldn't be use of any other artificial feeds or any other food, or even not even water.
Okay. For how many months? Can you repeat again exactly? Is it 6 months or 1 year?
So exclusive breastfeeding is done till 1 to 1.5 years.
No.
And in the first 6 months is only exclusively breastfed.
Yes.
Sorry, exclusively the child is fed till only first 6 months.
Yeah, only breast milk should be given for up to 6 months. That is exclusive breastfed. Apart from advised medications like ORS or drugs. Okay. Even water is not supposed to be given. Okay. Then as Sir told, actually folic acid pre-conception only we have to give to prevent neural tube defects. In under program we are giving 500 microgram to prevent anemia. Okay, under National Health Program we are providing 500 microgram to prevent anemia. Okay.
Yes.
Yeah, and child is immunized till date. Okay, immunization we'll talk later. Okay.
Okay, sir.
Yeah, you can go to next slide.
There's no history of fever with rashes.
Why you asked for fever with rashes?
Because there could be if there's infections such as like if there's any infection like chickenpox or because of toxoplasmosis, cytomegalovirus, and or if there's any infection, it can cause insult to the child, to the fetus.
Can cause?
It can cause insult to the fetus.
Okay. So to rule out torch infection, fine.
Torch.
Radiation. What is the safe limit of radiation
It
exposure in
is
pregnancy?
2 millisevere.
2 milli. Bedbug
2
units, you are saying.
millisevere or severe.
Okay.
Not
In
severe.
rats, 5 rats. Okay. 5 rats is a safe limit.
Okay, sir.
How will you classify drugs based on teratogenicity?
There is 5 categories: A, B, C, D, E.
And sorry, can you repeat?
So there are 5 categories:
Yes.
A, B, C, D, and E. No, I think it's X.
Yes. A, B, C, D, and X. Can you give example for category A drugs?
I'm not very sure, sir, of the different drugs and different categories.
Okay, just read about it. Most safe drug, even not magnesium. Folic acid is the safest drug. So category A is folic acid. Okay, most of the drugs come under category B and C.
Okay, sir.
Okay, and recently FDA has abolished categories of drugs, and they have moved on to we have to specifically write what effect it has on the pregnancy and lactation. Okay.
Okay, sir.
Okay.
Can you tell
one
about
thing.
what?
This one dating scan was done at 1 month. Usually, was it done at 1 month?
Yes, sir. When she came, that's when it was done.
4 weeks we usually don't see anything, no?
Yes. Yes, sir.
6 weeks is when we can identify fetal pole and cardiac activity usually at 6 weeks.
6 weeks.
4 weeks hardly we can see anything. So, okay. So dating scan you can say was done around 1.5 months.
1.5, yes, I changed.
And which corresponding to date. Since it's a dating scan, results are normal rather than results were found to be normal. You can say it was corresponding to date. And usually we comment whether it was a single fetus or multiple pregnancies. We can mention that. Okay.
Okay, so I'll mention that.
When NT scan is done?
NT scan was done it was in almost 2 months. No, it should be done 11 weeks.
Usually done between 11 to 14 weeks, 4 days. Okay, between in that period of gestation it is done. Okay.
Yes.
So is it sufficient to do NT scan, or what are the other screening modalities for Down?
Other screening modalities, we can check the levels of pregnancy associated plasma protein, and we can check the levels of the maternity serum plasma beta protein and beta HCG.
Okay, no, dual marker is serum beta HCG and PAPA. Okay.
Yes, sir.
Okay, beta HCG and PAPA is dual marker. Dual marker plus NT is sufficient in the first trimester. In the 11 to 13 weeks period of gestation. Whereas if she misses that period and she comes later, presents to you later, then we go ahead with the quadruple marker, which has better sensitivity and specificity than triple marker. Okay, I'll not go into detail. Beta HCG and PAPA, that is what you told, pregnancy associated plasma protein A. Fine. This one, what are the minimal antenatal visits required? How many visits and what period of gestation?
Yes, sir. The WHO says there should be 8, but according to Government of India, there should be at least 4 antenatal visits. First,
even WHO recommends minimum is 4. Okay.
Okay, sir.
Okay. So when and what?
Yes, sir. So the 4, it should be the first should be within 12 weeks of the gestation. Then second should be between 14 weeks and 26 weeks of gestation. Then the third one should be between 28 and 36 weeks of gestation, and the fourth one beyond 36.
28 and 32 weeks. Fourth one between 36 and 40 weeks. Okay. So what are the routine investigations you do? Blood and urine?
Yes, sir. In blood, we check for the hemoglobin. Then we check for the sugar, and then hemoglobinuropathies, and we check for the RH group, ABO grouping, and sugar levels. And
ABO grouping and RH typing, hemoglobin levels, then
VTRL we do.
VDRL.
And to rule out any hemoglobinopathies.
Okay, that will come at the end. What else? HIV, HBsAg.
Yeah, HIV, HBsAg.
Urine routine microscopy.
Hepatitis B and rubella.
Rubella.
Rubella, how do you?
We don't do testing for rubella, right?
Okay, sir.
Okay, so can you repeat again investigations?
Oh, yes, sir. For the blood, we check the hemoglobin. Then we check for the hematocrit. Then we check for ABO grouping, RH grouping. And we check for HbSAg and then HIV and VDRL.
Okay. What about thyroid?
Okay, so thyroid, TSH levels, then T4, T3, and free T3, T4 levels.
Everything you want to do. Okay, TSH levels are used. National recommendation is TSH alone. Okay. If it is abnormal, we can go for free T4. That is more specific in pregnancy. Since you know that thyroglobulin levels are increased in pregnancy, so T3, T4 levels can be increased, whereas free T4 always remains constant. Okay.
Okay, sir.
Okay. Well, you told about something hemoglobinopathies. Which test is being done?
For hemoglobinopathies, we can do spectroscopy.
Which one? Okay, I think Government of India recommendation is there for Nestrov to be done as a screening test for hemoglobinopathies. Okay, usually some of the hospitals do Nestrov as a screening test. If Nestrov is abnormal, they go for HB electrophoresis. Okay. Thilak sir, you want to add anything in first trimester?
Yeah. Why did you ask fever with rashes? You told some diseases. No. Can you tell about what is congenital rubella syndrome?
Oh, yes, sir.
Yeah.
If the mother is exposed to the rubella in the first trimester, then the child also might have chances of developing rubella. And then there is a triad which is seen in rubella. There can be cataract, there can be cardiac defects, and there can be even hearing loss.
Yeah. Can you tell what is the congenital defects, congenital cataract, congenital cardiac anomalies, and
hearing loss.
defect? Yeah, hearing loss. Okay, this is this. If it happens in the first trimester, all the triad can be seen. Okay, the same disease, if the mother gets in the third trimester, it will not affect the child. Okay, because by that time organisms will be over. Most of the organisms will be over. If it happens in the second trimester, it may affect, they say percentage wise, it may affect cardiac anomaly. It may cause cardiac anomaly, but not the cataract and hearing defect. But if it happens in the first trimester, since most of the organs not yet formed, it may cause damage to all the three organs.
Okay, sir.
Okay. Yeah. If the same thing, can you along with rubella, any other fever with rashes example can you give apart from torch?
Chicken pox.
Chicken pox. Okay. What if chicken pox comes in the first trimester? Any effect on the child? Means fetus?
Yes, sir. There is fetal varicella syndrome.
Oh, if it happens in the first trimester?
Not very sure, sir.
Usually first trimester, if it happens, child will protected because of the antibodies transmitting through placenta to the child. Okay, if it happens in the last trimester, there may be a chance, as I told, it may happen. Okay, but it is reverse for the rubella. If it happens in the first trimester, there will be too much of effect on the child or the fetus. If it happens in the third trimester, it will be less effect on the fetus. Whereas chicken pox reverse. If it is happening later part of the third trimester, child may get the varicella also. Okay, nothing but chicken pox. Yeah, you can continue with the second. And what is the opt-in for opt-out for the HIV? HIV testing.
Nisarga? Hello?
I think network is.
Nisarga, speak closer to your mic. It might sound better, I feel. Nisarga, you are there?
Yes, ma'am, I'm there. Can you hear me? Is it
Yeah,
better?
yeah. Please speak near to your mic. It might sound better. Hello?
Yeah.
Yes.
Yeah,
Yes,
continue.
ma'am, I can hear you.
Yeah, continue. You know what is opt-in, opt-out in HIV?
Not very sure, sir, but can I just try? Is it that they can voluntarily test, and if the ones who voluntarily get tested is opt-in, and who do not get tested is opt-out?
Yeah, actually, opt-out is for the means pregnancy. In pregnancy, mother doesn't have any role in telling I don't want to test it. Okay. In
Okay.
other scenarios, we can say, for example, any patient has come, we ought to do the surgery. If they say we don't want to undergo routine investigation, means routine investigation as a part of routine investigation, HIV testing. If they say we cannot do, we don't want to do it, we cannot force it.
Yes, sir.
Whereas in pregnancy, even mother says, I don't want to undergo HIV testing. She doesn't have a role in saying no. Okay, because
Okay, sir.
it is involves other life also. Correct.
Yes,
So
sir.
we can force her to go undergo HIV testing, even without our consent. Also means with consent we have to do. But
Yes,
we if she says I don't want to undergo, but we have the right to do the testing.
okay, sir.
Okay, but if we do in other scenarios without consult of without the consent of the patient, they may put a case against us.
Okay, sir.
Okay, we should be careful about it.
Okay, sir.
Yeah. And one more thing, whenever
Yes,
you
sir.
try to write months and all, no, in pregnant in history taking, in especially in pregnancy, don't write months. Okay, try to write in weeks.
Okay, sir.
Okay, weeks is very good. It's a very good method of assessing the progress. Okay.
Okay, sir.
Yeah. Continue.
Second trimester. The quickening was felt at fourth month.
So when is usually
6 week.
quickening felt?
Quickening is felt within 16 to 20 weeks.
Okay. So can you brief about vaccination in pregnancy?
Yes, sir. Vaccination normally, like previously, the tetanus toxoid was given, but now they have
Yes.
changed it to Tdap, which is tetanus, diphtheria, and acellular pertussis is given, and then the
See,
other.
Tdap is a recommendation by WHO. I think Government of India TD is being given. Pertussis is not being included still.
Actually, it's not started. I think only in few states as a pilot project they're doing it. I don't think
I
it's
think
been
Karnataka has adopted TD and we are
TD.
giving
Yeah,
TD here,
yeah,
routine.
okay, yeah. That's what in most it's started completely all over India. It's not started. If it's in Karnataka, it's there. You can tell that.
Okay, sir.
Yeah,
I'll make it. I'll say TD, sir.
and
Okay. Then
Then the other vaccinations that can be other injection that vaccine can be given is if we can give hepatitis B, and then we can even give for if rabies, for if there's an
okay, the immunization which must be given, immunization which are given based on situation, and immunization which should be avoided. Classify and that. Okay, so what WHO recommendation is for two immunization. One is Tdap, other one is
mm, I don't know, sir.
routinely they advise for the this influenza vaccine. Okay, so
Okay,
these
sir.
two are advised by WHO on routine basis, whereas others are if requirement is there, like rabies vaccine. If there is a dog bite, then you can give rabies vaccine. So most of killed vaccines you can give, whereas live attenuated vaccines
Live
are
attenuated.
generally avoided in
Okay.
pregnancy. Okay,
Yes, sir. Yes, sir.
so which suppose MMR, when can you give? She has not taken MMR vaccine
Yes, sir.
and she has come to you in pregnancy. You have done titers and she is negative. I mean, there is no antibodies. So what do you want to do?
Like because it's live attenuated, we cannot give her. We cannot give it during the pregnancy.
So when can we give her?
Mm,
Postnatal period. Okay, in postnatal
postnatal
period, if MMR and varicella vaccines are recommended after delivery. Okay, and
Okay,
if
sir.
MMR is given, she should not conceive for how many months?
She should not conceive for 8 weeks. Minimum
Okay,
6 months.
minimum 1 month gap is advised, and usually they say 3 months gap is better.
Okay,
Okay,
sir.
Nisarga, how many
Yes,
doses
sir.
of TT injection should be given for this mother in pregnancy?
Because sir, it is like less than 3 years, so we can give one booster dose.
One booster dose. If the gap was more than 3 years,
Then we need to give her two. We need to give her 2 doses of injection, which is 4 weeks apart.
yeah,
Previously, it was given after 16 weeks. Now it's recommended to give in the first antenatal visit,
yes,
and then after 4 weeks, the second dose.
okay, yeah, yeah. You can continue.
Second trimester details, and then 1 dose of TT injection was given. There was history of intake of iron and calcium tablets. There was
Yeah.
no
How much
history.
iron and calcium is being given? Dose of iron and calcium.
Yes, iron, the 100 milligram elemental iron should be given, and calcium it
We
is
changed over,
500
no?
milligram. Sorry, sir.
The current recommendation is for 60 mg elemental iron.
No. For
Okay.
Indian setup, it is 100.
Still, okay.
Yeah,
I
yeah.
got the recent guidelines by Government of India also, which says 60 mg elemental iron. That was based on WHO only, I think. Recently, WHO changed over. For prevalence more than 40%, they recommended, I don't know, Foxy recommendation also says 60 mg. Okay.
Okay, sir. 60 mg.
Okay. You can stick to, you can say 100 mg, 100 days, that is still there. They may be slowly changing over the recommendations. Excess of iron also has its own problems, increases the chance of infection, and so many things are there. It's always benefit versus the rest. Okay.
Okay, sir.
Okay. That is about the iron. Folic acid.
The folic acid, you said 4 milligram for preventing the.
Okay, that is 400 micrograms. But since the combination comes in 500 micrograms, usually we give 500 micrograms. Okay.
500.
Okay. What about calcium?
Calcium, 500 milligram tablet is given.
No. Current recommendation is 1.5 to 2 gram per day, but what we usually give is 500 to 1000.
Yes, sir. 500
Okay.
milligram, like 2 tablets is given per day, right, sir?
Yeah, current recommendations for 1000 mg, but it's a huge tablet. Compliance is a big problem, and that Thilak will discuss. So that's why we usually give at least one tablet that them take. And any role for vitamin D?
Yes, sir. In that tablet itself, 253 international units of vitamin D3 is present. So it
No, till
increases
now
the.
vitamin D was not recommended for pregnancy. Okay, except for the areas where vitamin D deficiency is present. Otherwise, we usually give only calcium. But maybe in present situation, vitamin D can be given, has been found to reduce the transmission of COVID. Okay, so you can vitamin D is beneficial, as well as vitamin C and zinc. Otherwise, routinely it need not be supplemented. What is required is iron and calcium, iron, folic acid, IFA, and calcium. Okay.
Okay, sir.
Nisarga, how do
Yes,
you
sir.
assess whether she's taking iron tablets correctly or not?
Sir, we'll ask her if the stool has changed color to black. That is one way we get to know if she's taking.
Yeah, okay.
So I'll continue.
Yeah, continue.
Yeah.
There's no
So why
history
you
of.
asked about those symptoms: fetal edema, epigastric pain, blurring of vision, headache, and vomiting?
So this is to rule out pregnancy-induced hypertension.
Okay. If the rest all last ones, epigastric pain, blurring of vision, headache are present, indicate severe preeclampsia, right?
Yes, sir. Pre-eclampsia.
Okay. Go ahead.
There's no history of excessive weight gain, excessive thirst, hunger, frequent micturition, and easy fatigability. There's no history of
Here you
heating
can
of.
mention that usually her BP will be measured, no, at visit. You can say there was no elevated BP recording, and screening for sugars was done, and they were found to be normal. You can just mention, right?
Okay, sir. BP recorded
What is
normal.
the screening method used for sugars? Hello.
Oral glucose tolerance.
Okay, glucose test. What are the various glucose tests? What is the commonly used Government of India recommendation?
Glucose tolerance test, sir. They give 75
Have you heard of
milligrams.
DIPSI?
Yes, sir.
What is DIPSI?
I don't remember, sir, in detail.
Diabetes in Pregnancy Study Group India. Okay.
Okay, sir.
So that is a study by Dr. Visheshaya. He is a pioneer in GDM in India. Okay.
Okay, sir.
So they suggested, you know how to do DIPSI?
I think, sir, we give 75 milligram of glucose to
75 grams of glucose.
Yes, sir. We give it to the patient, and then we record the glucose readings every 1 hour.
Okay, patient presence, irrespective of the fasting status, whenever the patient comes, irrespective of fasting status, we give 75-gram glucose to her. Okay,
Yes,
and we measure blood sugar levels after 2 hours.
okay, sir.
If it is between 120 to 140, we consider impaired glucose tolerance. If it is more than 140, more than or equal to 140, we label her as gestational diabetes mellitus. And if it is more than 200, we call it over diabetes. Okay. This is done when?
Sorry, sir.
When are you doing this test? Which period of gestation you are doing this test?
In the second trimester.
Okay, I think the current recommendation is for in the first visit itself. In all Indian women are at high risk for GDM because of the ethnicity. First visit you have to do, repeat at 24 to 28 weeks, then at 32 to 36 weeks. Okay, in first visit, if reports are normal, then repeat at 24 to 28 weeks. If normal, repeat at 32 to 34 weeks. Okay.
Okay, sir.
And this is a single step test. It is both screening as well as diagnostic. The values come more than 140, we label her as GDM. Whereas glucose challenge test and oral glucose tolerance test are a two-step test. First, you do a screen with GCT, that is 50 gram we use. If it comes more than 140, we go ahead with the OGTT, that may be 75 gram or 100 gram, depending on which method you are using. There is the IADPST method and Carpenter-Coston method. And NDDG method is also exists. Okay, that we'll discuss later. Not in this class. Okay, at least DIPSI you should know, which is commonly practiced in India.
Okay, sir.
It has the advantage that women need not come in fasting status.
Yes, sir.
Indian women come to hospital only very seldom, and whenever they come, you just catch them and do all possible tests and screen them, identify the high risk factors. That is the aim. Okay.
Okay, sir.
Okay, fine. Thilak, anything to be in second trimester?
Nothing. No, okay, nothing. Why did you ask leaking fever, bleeding PV?
That is to rule out any complications.
Which is the commonest cause for loss of pregnancy in first trimester?
In first trimester is the spontaneous abortion.
Yeah, what is the reason for spontaneous abortion?
It's a trisomies.
Yeah, trisomy is correct. What is the one of the commonest cause for second trimester pregnancy loss?
Not sure, sir.
Cervical incompetency. That is one of the repeated pregnancy loss. If it is happening in second trimester, that is one of the cause. You have to look for it. Okay. Yeah, you can continue.
Third trimester, the patient, she continued to perceive fetal movements. She continued to take iron and calcium tablets. There was no history of fetal edema, epigastric pain, blurring vision, headache, vomiting. There's no history of excessive weight gain, excessive thirst, hunger, frequent maturation of fertility. No history of leaking.
What is excess weight gain?
It's excessive weight gain is if the patient is gaining more than 3 kgs per month.
Indicate?
It is one of the first signs of preeclampsia.
Very good. Okay. Go.
So can I continue?
Continue.
What is the normal weight gain can happen for a pregnant mother during the course of pregnancy?
Weight gain between from 9 to 11 kg.
Yeah. Okay.
Then there was no history of leaking or bleeding PV. The interval growth scan was done and the report was normal, and the routine investigation was also normal.
In third trimester, what routine investigation will do?
Again, we'll check for the sugar levels.
Yeah, correct. Now, what is what is the definition of pH actually?
PIH, if there is increase in the blood pressure more than 140, and which is taken at two separate readings, which is in the interval of 4 hours, and if it is seen in pregnancy, then it is pregnancy induced hypertension.
Okay, what is the pregnancy cutoff? How many weeks we take?
Sorry, sir, I didn't understand.
Gestational age. For example, if the pregnant mother is having the BP of 140/90 at the pregnancy time during around 16 weeks, do you say that's pH?
I'm not sure, sir, which the cutoff.
If it is above 20 weeks only, we can say it is pH. Before 20 weeks, if the blood pressure is more than 140/90, then it may be hypertension because of other causes.
Okay, sir.
Okay. If it is only after 20 weeks, same as in diabetes, gestation diabetes also, we have to consider gestation diabetes only if it is more than after gestation age of 20 weeks.
20 weeks, correct.
Before that, it is maybe diabetes mellitus type 1 or type 2.
Yes, okay, sir.
Okay, this cutoff you should know.
Okay, sir.
Yeah, okay.
Marriage history, she was married for 3.5 years. It's non-consanguineous marriage. Menstrual history, his menarche was at 14 years, regular cycle of 28 days. Her duration of menses was 3 to 4 days, and the number of pads used was 3 to 3. There was no history of passage of clots, and there's no history of dysmenorrhea. Her LMP was 3rd May 2019, and the expected date of delivery was 10th February, and her obstetric score is G2P1L1.
How you calculated EDD?
Or EDD, we use the Naegeli's formula, and we add 9 months and 7 days to the LMP.
Okay.
What is the age of the child, first child, Nisarga?
Now at present is 3 years, sir.
What is the married for? They're married for? The marriage history is married for how many years? Okay, that's why we usually tell under 5 children means you try to write in the months.
Okay, sir.
Okay, this confusion will be not be there.
Okay.
Okay.
So she's a booked case and a registered case.
So what is booked case and registered case?
So booked case is if they're at one institute itself, she's having at least a minimum of three antenatal visits.
Four.
Okay.
Then and she at least should take.
And she should take the iron and folic acid tablets.
100 iron folic acid tablets, and
she should be immunized with
two TT injections if it is first pregnancy. If it is second pregnancy, within 3 years, 1 TT injection. Okay. When should be registering the? What is the ideal time to register the case pregnancy?
In the first antenatal visit only it will be.
Yeah, first antenatal visit only they have to register, preferably within 12 weeks of the pregnancy.
Past history. There was no history of diabetes mellitus, hypertension, or any thyroid disorder or epilepsy. There was no history of any drug intake. The details of the ANC care. Number of the ANC visits was 4, and the iron and folic acid tablets were taken. And there was history of the TT immunization, 1 dose. Sorry, sir, that's a mistake, just 1 dose.
Okay.
Family history.
Okay.
Yes, sir.
Nisarga, 1 minute. 1 minute. After when they married means they After marriage, immediately she got
Yes, after
pregnant.
3 months, she
Okay, okay,
conceived.
yeah, okay.
Family history is nothing significant. Nothing significant. Personal history: her appetite was good, sleep undisturbed, bowel and bladder movements normal. There's no addictive habits, and her personal hygiene was good. Her diet history: 24-hour recall method.
Mm.
In the morning, 8 a.m. she used to have idli, sambar, and
Okay, okay.
roti.
No need to tell all these things. Can you just tell
Okay.
me what is required kilocalories for her?
Oh yes, sir. Like for her the total calories required is 1,995 kilocalories. Normally in pregnancy, we need from the normal regular intake there should at least be 350 kilocalories increased. So with
Okay.
that calculation for her, it should be 1995 kilocalories.
No, no, you telling little bit.
Oh, no, sorry, sir. Her it should be 2,250 kilocalories, and according to the calculation, hers it's 1,995, and she's deficient by 255
Okay.
kilocalories.
So how did you calculate this? Expected is 225. Sorry, 2250.
Yes, sir. For her, her normal, because she doesn't do much work, so we're considering sedentary. So it was 1900, which was a normal. And now in
Okay.
pregnancy, the increase should be at least minimum 350 kilocalories. So on adding that 2250.
Okay, okay, yeah. So if whenever we try to tell the diet history, no, you tell
Yeah.
directly. She's a since she's an housemaker, we think she is a sedentary worker. So the expected kilocalories for her this month 1920. So in pregnancy we have to add extra 350 kilocalories. Total expected kilocalories this much.
Okay.
One sentence you can say. So this much she's taking. Total calories 995, and deficit is this much.
Okay. Yes. Okay, sir.
Okay. So in one sentence, if you tell, examiners will be happy.
Okay, fine, sir.
Yeah.
And her expected protein intake should be 78 grams, and according to calculation, came up to 67, and she's deficient by 11 grams.
Yeah.
What's the routine protein requirement?
Protein is, like in like trimester wise, sir.
No, overall, you tell what is the requirement in the
Overall for
pregnancy.
her, which was calculated, was 78 grams.
How
How
did
do
you
you
arrive
calculate
at?
it?
So this I've taken it from the PSN textbook. Like for the
Okay.
sedentary life,
Approximately
1.5
1.1
grams.
gram per kg per day.
Sorry, sir.
So 1.1 gram per kg per day is the requirement. And what about iron? What is the requirement daily?
Iron. Not sure, sir.
So what are the micronutrients which are important? You
Okay.
should know about iron, calcium, and all. Okay, they may go for that. 6 mg is in the second and third trimester, 1 mg in the first trimester.
Okay, sir.
Okay.
So can I continue?
Yeah.
Yeah.
Family and environmental study. The type of house is Pakka house, and there was no presence of overcrowding or ventilation. The lighting was adequate. There was no mosquito breeding areas or fly breeding areas. There's no rodents and there's no pets in the house. The kitchen is separate. The storage of cooked food is in copper vessel and it's covered. Uncooked foods in the shelves and it's kept covered. Fuel that is used is LPG. Chimney is present and there is separate area for washing utensils, and the drainage is closed. Water supply continuous through taps. Source of drinking water Kaveri. Storage is container covered, and the purification of water is boiling, and water for other purposes is provided by the municipality. And the refuse disposal covered in a box in the house, and is disposed once in 2 days in a common dustbin in the locality, and then later it is cleaned by the municipal authority. The latrine, they have their own. It's an RCA latrine, and there's a tap also which is with continuous water supply. And hand washing practices is there with soap. And then social. Can I continue with social history, sir?
Yeah. Any important findings, environmental history findings are having any impact on the mother's pregnancy?
With respect to the family and environmental, sir,
Yeah, yeah.
uh, if they are like hand washing practices and all are necessary, and
Mm-hmm.
then if any if they refuse, like if it's not stored and all fly breeding, and also that could increase the risk of any infection.
Okay. Yes.
And even purification of water, like she should drink like they're using boiling, so she should make sure that anytime she's consuming water it should be boiled.
Yeah. Okay, you can continue.
Social history. Food taboos were present. She should not eat papaya, pineapple during first pregnancy, and she's following the same now. And there are no other cultural practices. And when we asked her about the knowledge, attitude, and practice, it was good. So can I continue?
No other cultural practice means what cultural practice you expected?
Like so sometimes like before like in the pregnancy they can have those pre-lactal feeds giving
Yeah.
of honey or jaggery,
Mm-hmm.
or if they have like the culture of branding and all if it's a specific gender of child.
Yeah, correct. Okay.
Can I continue?
Yeah, again.
General physical examination. Her consent was taken and she was cooperative. She was oriented to time, space, and person. Examination was done under adequate exposure to light. Patient was of moderate build. Her BMI is 23. Her pre-pregnancy weight is 60 kgs, and the height taken at that time 160. Her vitals.
You can mention the present weight, okay? We'll know the weight gain also with that. That you can measure anyhow.
Okay, sir.
Okay.
And is it necessary to mention BMI in pregnancy?
Yes. Oh, you're asking the question.
Yeah.
Role of BMI in pregnancy.
Yes, sir, because we need to make sure that she's not any risk for obesity and all, because that will also increase its risk factors for
See,
gestational
I will
diabetes.
tell. Actually, BMI, when you calculate in pregnancy, it is not an accurate method to calculate the weight gain and all. Why? Because definitely it's a physiological process. The baby is growing inside, and the placenta is also is growing. All other liquor, everything is there. So the mother who is in the borderline, she may go for overweight. Do you mean to say she's overweight? Okay.
Okay,
For
sir.
that, there is a different calculation to calculate in BMI for pregnancy. Okay. We
She
don't.
knew the pre-pregnancy weight, so you may mention the BMI. Okay? If you
Yeah.
Yes,
know
because
the pre-pregnancy
BMI
weight,
is calculated with the pre-pregnancy weight.
Oh, you
yes.
calculate with
If
the
you know, you
pre-pregnancy
can
weight.
mention.
Yeah, yeah. You have to mention that. Okay.
Yes, sir, that's the one.
Okay. Otherwise, see, it will be too much of confusion.
Yes, sir.
Okay. Yeah.
Vitals.
So, obesity, what are the problems? Just briefly.
There can be increased risk for gestational diabetes.
Yes. For everything, gestational diabetes, preeclampsia, thromboembolic events. Okay. They are
Okay, sir.
more prone for macrosomia and cesarean section. There are a long list. Just go through it. Okay.
Okay, sir.
But at least mention preeclampsia and GD.
Okay, sir.
Okay. So, what is normal pulse in pregnancy?
Normal pulse is between 60 to
Okay, it
90
increases
beats
by
per
10
minute.
to 12 beats in pregnancy. Okay, there is increased heart rate, increases by 10 to 12 beats. What happens to respiratory rate?
Sorry, sir.
What happens to respiratory rate?
Respiratory rate it it increases a bit. Not very sure, sir, but I
It
think one
remains
thing is
same
towards
in
the end of the
pregnancy.
pregnancy becomes purely thoracic.
No, it remains same. Okay,
Okay, sir.
there is increase in tidal volume, but respiratory rate usually remains same.
Yeah.
Okay,
Okay, sir.
tidal volume increases because of progesterone's effect on the pulmonary center in the this one brainstem. Okay, what's the role of temperature? Why you mentioned temperature?
That is just normal the examination, sir.
Any role in the present situation? You have to check temperature and SpO2. Okay.
Okay. So in present situation, yes, sir.
Okay. Since you mentioned 90 mmHg, now you define. See, usually in OBG we differ from the word PIH. Okay, that's little older terminology. We use hypertensive disorders complicating pregnancy as a overall terminology. And if we specify, we are very happy. Like whether it's preeclampsia, gestational hypertension, chronic hypertension, or preeclampsia superimposed on chronic hypertension. These are the four words which commonly used. Overall cover word is hypertensive disorders complicating pregnancy. Okay.
Okay, sir.
Okay. Just briefly tell about how you measure BP, and then we go with the definitions.
Okay, sir. We if she was made to sit in the sitting position in her right arm, we just use the sphygmomanometer and we record it.
With sphygmomanometer?
Put the cuff in her right arm and
you have to tell full. The sphygmomanometer should be at the level of the heart.
Okay,
it should cover 2/3 of the arm width, and it should be 1.5 times the length of the arm circumference.
Okay, sir.
Okay.
Okay, sir.
Then which Korsakoff sound is taken as systolic, which is taken as diastolic?
Okay, sir. I'll revise that, sir.
Okay, fine. Go ahead. So what is definitions? Can you just tell?
So definition of
hypertensive disorders complicating pregnancy in detail, like preeclampsia definition and gestational hypertension definition.
Okay,
at least preeclampsia definition.
Okay, sir. If the BP reading is more than 140 by 90, two readings which is separated by 4 hours, and that is seen in pregnancy, then we say that it's and it is after 20 weeks, then we say it is hypertensive disorder which is complicated in pregnancy.
Okay, so what is preeclampsia?
In preeclampsia, if the diastolic blood pressure increases to more than like 110, then we say it is preeclampsia.
Okay, so BP recording of more than or equal to 140 by 90 millimeters of mercury after 20 weeks period of gestation in a previously normotensive women associated with proteinuria or any other features of severe preeclampsia, then we call it as preeclampsia. Okay.
Okay, sir.
Okay. Whereas absence of any features of severe preeclampsia and proteinuria will label her as gestational hypertension.
Okay, sir.
Okay. So you know the signs of severe preeclampsia. Can you just brief it?
Sorry, sir. The signs of preeclampsia.
Severe preeclampsia.
Severe preeclampsia.
So preeclampsia is classified as preeclampsia with severe features and preeclampsia without severe features. Previously, they used to call mild, moderate, severe. That terminology is also gone. Now we call preeclampsia with severe features, preeclampsia without severe features. So you know what are the severe features?
Yes, sir. There is a decrease in the frequency of the micturition. There is headaches, and then there is epigastric pain.
Okay, one is headache, epigastric pain, and blurring of vision.
Blurring of vision.
Okay, then there is thrombocytopenia, elevated liver enzymes, then elevated creatinine level or decreased urine output. Okay.
Okay, sir.
And hemolysis. All this constitute the features of severe preeclampsia. Okay, go ahead.
Pallor not seen, icterus not seen, clubbing not seen, cyanosis not seen, lymphadenopathy, and edema was not present. The breast examination was normal, thyroid was normal, spine was normal, and systemic examination.
What are the causes of edema in pregnancy?
Yes, sir. Like there can be even physiological edema because of the gravid uterus which is pressing on the veins, and then they can. And then otherwise, if they have chronic anemia, then that will also cause. And if there is heart disease, or if there is even in preeclampsia, because of proteinuria also, you can see edema.
Preeclampsia as well. What breast examination have you done?
We just check for the nipples, if it's flat, if it is normal, or if it is flat or retracted.
Any sore nipples? Okay, fine. Go ahead.
And how do you differentiate between physiological edema and pathological edema in pregnancy?
Oh yes, sir. Physiological edema, it's like mostly seen towards the evening, and then after rest and when they get up in the morning, the edema is not present. But in pathological edema, it is continuously present the whole day.
Yeah. Okay. Good.
And signs of pathological edema, additional signs may be present along with the edema. Okay.
Additional signs. Okay, sir. Systemic examination, CVS, S1, S2 is heard and no murmurs. Respiratory system, normal vesicular breath sounds are heard, no other added sounds. And CNS, no pulmonological deficit. Per abdominal examination, in inspection, the shape of the abdomen, globular, longitudinally distended. The umbilicus is central and everted. Flanks were full. Linea nigra is seen. Stria gravidarum is seen. No other pulsations, scars, or engorged veins seen. And the hernial orifices were intact. Shall I continue?
Yeah, continue.
Palpation, the fundal height, 36 weeks. Symphysiopundal length is 36 centimeter. Abdominal girth at the level of the umbilicus was 95 centimeter. The Leopold manuals. Fundal grip, soft, broad, and non-ballotable, suggestive of breech. Lateral grip, uniformly curved structure on left side, suggestive of spine. Knob-like structures on the right side, suggestive of limb buds. Pollex grip, approximation of fingers suggested hard, globular, ballotable structure, head. Pelvic grip, fingers are converging, see the head is not engaged. Auscultation, fetal heart sound heard on the left side, and it was 144 beats per minute.
So, diagnosis.
Clinical social diagnosis. 24-year-old female named Pavitra from Kengeri, studied till second PUC, belonging to a joint family of socioeconomic status lower middle, according to modified Kuppaswamy scale. She is a Thai card holder and is admitted for safe confinement. She is living in good environmental conditions with proper housing, lighting, and ventilation. She has good social support, and her knowledge, attitude, and practice is good.
You didn't mention anywhere she's a pregnant. In your diagnosis, nowhere it is mentioned she's pregnant. Admitted for safe
Parity
confinement.
index.
Yeah, parity index. You're right.
And obstetric score.
And period of gestation as well, you have to write, okay? So she's, like when you come to OBG, she's 24-year-old, 24-year-old gravida to para one living one at 38 weeks period of gestation with single live intrauterine fetus in cephalic presentation. Okay, for safe confinement.
If any complications are, you mention the complication. If no complication, no, without complication, you can mention.
Okay, sir.
Yeah.
You mentioned BP 90 mmHg, okay? They'll definitely go towards that.
Yeah. So see, be always careful. Whatever you tell, no, write in the case sheet, or you tell in during the case discussion, you should be confident. If you don't, if you say something and if you're showing something else in the patient, so they may think you're not examining the patient. Okay. So always cross verify before you tell the things.
Okay, sir.
Okay, next.
Management at the individual level, dietary advice is given, and advice on the personal hygiene, care of the baby.
So what dietary advice you're giving?
We should just make sure that she eats, like there should be little more increase in the amount of calories that she takes, and like little bit more than her normal food, and there should be increase even in green leafy vegetables and foods which are rich in carbohydrates and proteins, pulses, cereals.
Okay, so if in this case you mentioned around she's having 200 to 220 kilocalories deficit and around 11 grams of protein deficit.
Yes, sir.
how do you try to adjust that?
Yes, sir. We would just try to say that from her normal quantity, maybe she could increase, like she was having like 3 or 4 idlis, maybe she could eat one extra, and she could have more fruits and vegetables.
Which fruit
And
she can have, which vegetable she can have. See, this is the problem with us. We always try to tell very generically. We try to tell. Okay, we are not supposed to tell like that. We have to tell what exactly they have to eat, what type of food they have to eat. We sometimes for diabetic patient we say you should eat less carbohydrate rich food. How they will come to know what is the carbohydrate rich food, what is carbohydrate less food, correct? So we have to at least give some examples.
yes, okay.
Yeah, tell me some examples. So how do you want to
So
increase that protein?
yes, sir. Since she is not like any risk for GDM cases, so we can tell her to have a lot of beans and green leaf vegetables, and then she can
Yeah,
have a lot of potatoes.
potatoes only carbohydrate it is. So you can
Yes,
ask
but
her to see.
increasing the calories.
Yeah, no, see, protein also will give calories.
Yes, sir.
Don't think differently. Protein and protein also gives calorie.
And
So if you try to compensate the proteins, automatically calorie also will be taken care.
yes, sir.
Okay, if she's non-vegetarian, you can add her to take daily
Add
one or two eggs.
yes.
Okay, it will almost 6 to 12 grams of if she's taking two eggs, she will almost 6 to 12 grams of protein will be covered in that one only.
Yes, sir.
Okay, if she take add just two eggs in a day, it will cover almost. Okay,
Yes,
then you can ask them to take the food which are locally available. Okay, locally available, we can ask them to eat, like for example this is a season for some fruits, so we can ask them to take seasonally available fruits, and tell them to increase the green leaf vegetables. Okay, so we always sell green leaf vegetable examples for which are rich in iron, like uh, drumstick leaves, then palak. Okay, then that is nothing but spinach. Then we can ask them to eat drumstick leaves. Then some people are very fond in Bangalore. We very commonly we see people eating chickis, correct?
okay, sir.
Chicky is a very rich source of iron and protein.
Okay,
Okay,
sir.
you can tell all those things. Locally available food we have to tell. Okay, generally if you tell just we have to increase the protein content and all, they will not know. And if
Yes,
they're vegetarians, you can ask them to go for the soya bean, which are rich in protein and all. Okay,
okay, sir.
yeah. Personal hygiene, what you are trying to tell personal hygiene?
In personal hygiene, we should just make sure that they are like bathing regularly, and the clothes and all they are like washed regularly, and her there should be like other hygiene like the nails and all they should be cut. They should be well groomed,
Hmm?
and then we can make sure that they're taking good rest
Hmm?
and adequate rest. They should, and sleep also should be there, and
Yeah,
like to prevent and then good food intake.
yeah. How much sleep she should have?
She should have like a minimum of 8 hours of sleep, and after the meal, like the midday, also she should take at least 2 hours of rest.
Yes, that is very important. Okay, yeah. Next. So care of the baby, you're going to educate her regarding the care of the baby.
Care of the baby.
Okay. So breastfeeding practices. So what you're going to tell her regarding breastfeeding practices?
Like firstly, we should like tell her that first we should encourage the breastfeeding practices and tell her how it's beneficial for the child, it's beneficial for her, it increases the bond.
Hmm.
And then we need to make sure that she's like breastfeeding like properly to the child, like there should be proper fixed attachment, otherwise the child will not be able to get the milk properly.
Yeah.
So to ensure that there is a fixed like proper attachment, we should make sure that the lip of the like we tell this that the lip of the child should be like turned outward, and
Hmm.
then the chin of the baby should be touching the lower part of the breast, and the total mouth should be covering the areolar surface.
Yeah. Okay. And within how many hours for normal delivery you should initiate the
Within
breastfeeding?
1 hour of delivery, we should ask the mother to breastfeed.
In cesarean section? If it is cesarean section,
Then maybe just 1 hour, 1 to 1.5 hours.
Now within 4 hours you have to start initiate the breastfeeding within 4 hours.
Okay, sir.
Okay, if you start early, it's good.
Okay, sir.
Okay, yeah. What is baby friendly hospital initiative?
Yes, so in baby friendly, so there are like some 10. There is a policy. So first we
Yeah.
need to implement the policy and we need to make sure that the parents avail it. Then second is the health workers. They should be trained about the with the skills related to these policy.
Mhm.
Then we should tell the mother about the benefits about breastfeeding, and we should tell her to start breastfeeding as soon as possible, at least like within half an hour, 1 hour.
Yeah.
And then we should make sure that there's only exclusively breastfed,
Yes.
and there should not be any like any other feeds or any other food that should be added. And then we should make sure that we should discourage the use of feeding bottles and
Mhm.
any other dummies and pacifiers who should not be used. And before any discharge, we should make sure that there are some support groups so that they can go and even speak to.
Yes. Good. Good. Okay. So what else you want to tell regarding the planning, family planning methods?
In family planning, we should at least like make sure, because now they have already had the second child,
Mhm.
so we can tell them that they can go for sterilization.
Yeah, sterilization. Which one is the ideal method?
Ideal method, because now she's like, if we can ask if she like completed her family, then maybe after 6 months she can get her tubectomy done,
See,
or
it's not
now she can
tubectomy.
use.
Ideal method is not tubectomy. Last class also I told, I think.
Can make her use an IUD.
No,
Right?
no, no. Ideal method is vasectomy.
Yes, sir.
See, we have to change this mindset. Family planning means nothing, not only females. Okay,
Yes, sir.
it's couples. It's always eligible couple. Okay, you have to think about the male husband also. Okay, otherwise we always think about tubectomy. Okay,
Yes, sir.
we have to focus on as a couple. We have to give the all the available options like cafeteria approach. We say all the available family planning methods. We have to tell them. It's better to ask, tell, for example, these are the benefits for if you go undergo vasectomy, if you undergo tubectomy, these are the benefits. We can tell. Okay, ideal method is vasectomy, but there are so many stigmas associated with. That's why people go for tubectomy. But it's okay. If they are doing cesarean section, definitely it's better to go for tubectomy because anyway they opened, they can do the tubectomy there itself.
Okay, sir.
Yeah. That's why I try to listen to the question properly. I ask ideal method. Ideal method. Okay,
Okay,
ideal
sir.
method is vasectomy. Yeah. Abhilash, anything you want to add?
No, the OBG management, I think we can discuss in OBG class. Uh,
Yeah. Yeah. OBG man.
any
We can.
other class,
Yes.
it's
Yes. Yes. Okay.
detailed.
Okay.
We can discuss both
Yes. Yes.
examination
Yeah.
and this
Yeah.
thing.
Yeah. Okay.
Nothing else, I think. In this.
Yeah. Okay. So I just wanted to ask some questions regarding what is essential and emergency obstetric care. Yeah. Nisarga?
Sorry, sir. Could
Essential,
you repeat?
essential, and emergency obstetric care.
Sorry, sir. I couldn't get you.
Essential
Yes, sir.
obstetric care. Audible now?
Yes, sir.
Yeah.
Essential obstetric.
What are the components of essential obstetric care, and what are the components of emergency obstetric care in under PHC or under NRHM or under RMNCH plus A? What are the programs we are having? Okay, these two are actually short notes for you. Essential obstetric care and emergency obstetric care under RMNCH plus A is a short notes for you, so you can read about it.
Okay, sir.
Okay. So essential obstetric care means safe delivery should be done. So institution delivery should be done, and along with that, if any small complication happens, it should be handled. In emergency obstetric care, each PSC should be able not PSC CHC at least should be able to have 24-hour delivery services, blood bank, and if possible, there should be availability of the obstetrician with the emergency in cesarean section availability like OT setup and all. Okay, like with anesthesiologist and all. Okay, these are the emergency obstetric care. So that is a important question for you, so you can read about it. Okay,
Okay, sir.
then one more question I want to ask is they will ask what are danger signs in pregnancy. You already mentioned some danger signs, like what are the signs and symptoms of preeclampsia pregnancy, bleeding PV, and all those things you mentioned, placenta previa and all. No, so those are the comes and danger signs in pregnancy. They may ask you as a short answer. So mention danger signs in the pregnancy, like short answers. Okay, you can talk about it. Okay, anything else you want to tell? What avoidance of drugs you want to tell?
Like, normally also, I mean, just to say that they shouldn't take it, because just to like prevent the risk of teratogenicity. Sir.
Yes. Okay. Okay. Then in this management, no, so we can always tell about the, so why it is important to talk about breastfeeding practice and family planning methods now itself, during pregnancy itself. Okay, they will ask, because this is a time where we can make the females will be very much receptive for the family planning methods in the during pregnancy time. Okay, so you have to tell them. So advance only you have to tell. Whenever you opportunity you get, you try to tell about the available family planning methods, so so that they can choose a method. Okay,
Okay, sir.
then breastfeeding practices you have to start as early as possible. You have to tell them to teach how to do. Even though they're having one child already, you have to again reassure them or remotivate them to give the exclusive breastfeeding for this child also.
Yes, sir.
Okay,
Yes, sir.
yeah, okay. So dietary same thing you will repeat in the family level. We can advise those things in the family level. Okay, can you
Okay,
go
sir.
to next slide?
In family level, make sure that the mother is getting like moral and social support from the other
Yes,
family members,
yeah,
and she's getting adequate rest,
yeah.
and providing the mother food enriched in calories, and they
Mm.
should and we should encourage immunization of the child,
Yes,
and the
yes.
family members also should be
Yeah,
reminded
yeah.
about it.
Yes, yes, that is important. Immunization of the child is very, very important. So we can sometime we can discuss about immunization as a whole in India, what we're following as a separate thing we can discuss once. Yeah. So you can go to community level. This is important. This is the important part where most of discussion will happen in a clinical social case. Yeah, you can go to next question. Next part. Community level.
I said community level, she can avail schemes like the Taika, which she's availing right now,
Mm.
and then Ayushman Bharat, then Janani Shishu Suraksha Karyakram, then
Mm.
Navjat Shishu Suraksha Karyakram, and then
Mm.
reproductive and maternal and child health and adolescence,
Mm.
and then Janani Suraksha Yojana and
Mm.
Rashtriya Bal Suraksha Karyakram.
Okay. What about ICDS? ICDS is there any?
Yes, okay, so I'll include that.
Yeah. So Thai card. What are the components are there in Thai card? So different states having different name for the Thai card. Okay.
Okay, sir.
So you can mention that if the any external examiner comes, you may have to tell this is a maternal mother and child health card.
Okay, sir.
Yeah. So what are the components are there in Thai card?
In Thai card, she can show this at every antenatal visit, and she can get these services.
Hmm?
And
So have you seen Thai card? What are the things are there in Thai card?
no, sir, I've not seen.
Okay, okay. You can see in even in net it is available. If you go and see in Ministry of Health and Family Welfare Karnataka also will get NRHM website. Okay, in Karnataka website also will get. Otherwise you can see in this one. So it will consist of Thai card is a initially we used to give different cards. Okay, what I'm talking about 15 years back, we used to give different cards for the mother separate card, child separate card. Now we are not doing like that. What we are doing, everything is in same card. So it will consist of ANC card, ANC. It will consist of PNC, that is postnatal care. Then it will have growth chart. It will have immunization chart for the child, and also what breastfeeding practice should be followed. Okay. breastfeeding practice, education component will be there, and also along with that we will be having the diet, what are the important things to be eaten during the pregnancy, during lactation, everything will be mentioned in that as education component. Along with that, it also will have regarding the about the family planning methods also. If it is there any taking any method, that also may sometimes they will include as an education component. Okay, it consists of all these things regarding ANC, PNC, immunization of the mother and immunization of the child, then dietary advices, then breastfeeding advices. Along with that, the growth chart will be there. So it is as a compact. So every time no need to bring so many cards. So within this one card, they can have all the things. And one important thing what they've done is they have given unique identification number for this Thai card. Okay, so if the child has gone, if the mother has gone, initially she is registered in Bangalore. Okay, but her native is, means our mother place is say it is in Shivamogga or some part of the Karnataka. Okay, if she takes that card and she goes to Shivamogga, because of the unique identification number, she can avail the same benefits in the same in that place of Shivamogga also. Okay, so because of the unique identification number. So, and initially what is to happen, they used to register in Bangalore also, and they used to register in Shivamogga also. There should be duplication. To avoid duplication, they do they are doing this. Means okay.
Okay, sir.
I don't know whether it is valid in other states, because somebody has asked whether it is valid in other states. I'm not sure, but within state it is valid. Thai card is not given in private hospitals. It is only if you register in a government setup, then only you will get it. But we always tell, somebody asked, okay, since somebody asked, I will just repeat here. What is booked case and registered case? Registered case means whenever a pregnancy has been registered by the pregnant mother or by the ASHA worker in any government health portals like PHC, or by ASHA worker to the PHC, if it is reported, that is a registered case. Okay, if she finishes all the minimum basic requirements of ANC case, that is 4 ANC visits, 2 TT injections, the 100 iron folic acid tablets, okay, then it is a booked case. Okay, these are the differences. Okay, so can you tell me about what are the benefits, what are the services mother will be getting under JSY scheme? Mother and ASHA worker.
Sorry, sir, could you repeat?
JSY scheme. Under JSY scheme, what are the benefits she's going to get?
Yes, sir. In Janani Suraksha Yojana, they get the benefits, and if they do early registration, so they get these, especially like it's divided like in low performing states and high performing states.
Yes, yes.
And in low performing states, like all women in all the different setups, they get some amount from the government.
Yeah, how much amount you should know, okay? Because Karnataka is a high performing state, so you should know the Karnataka's number. It is around 600 to 800 rupees, I think. Okay, then how much will be taken by the ASHA worker also for each pregnancy registration and institution delivery?
Yes,
How much?
In the urban setup they get 400, and in the rural setup they get 600 rupees.
Yeah, okay. Okay, can you tell me what is the main difference between JSY and JSSK?
Yes, sir. In JSSK, it is like when they have the GSY includes JSSK, and JSSK is mainly that if they come for institutional delivery, it will be free of cost.
Yes. So JSY is to promote institution delivery. Okay. The main aim why JSY they introduced is to promote institution deliveries. Whereas JSSK, once they come to institution, they may face some challenges, like because they may not have some amount and all, no. So to avoid that, JSSK has come. So JSSK they give full free delivery in case of normal delivery for 3 days admission, and with diet also. In case of cesarean section, 7 days admission with diet and consumables and operation. Everything is free. Okay. In case of child developing any sickness, okay, for that up to 30 days, all other things will be free. That is JSS. In JSY, the mother and ASHA worker will be getting the monetary benefit, and it will be given directly to the account. Direct benefit transfer will be there. Okay, that is the main difference. And there is one more thing called as Vande Mataram scheme.
Yes, sir.
So what is Vande Mataram scheme is, in case of
they volunteer to help in, there are doctors or healthcare professionals who volunteer to help and assist the
yes,
mothers
yes.
and all for antenatal services.
Actually, for example, I am having a OBG clinic, private clinic. Okay,
Okay, sir.
if I am willing to join a Vande Mataram scheme, I can join the Vande Mataram scheme, so that if anything I do, operations and all those deliveries, it will be free of cost for that person. Government will be paying me the amount. The respective amount will be we paying. It's like insurance. Okay, the government will be paying me the amount. That is Vande Mataram scheme. Okay, then what are the benefits you will be getting under ICDS for a pregnant lady?
Not sure, sir.
You have to read. Okay, there is one nice beautiful table in pregnant this one. So she'll in Anganwadi, what things we'll be giving? We will be giving the mainly basic about the supplementary nutrition. Okay, so she will be getting the supplementary nutrition. Then she will be getting the education regarding the health education regarding the breastfeeding and family planning and other hygiene methods. Then she'll be also she can avail the service of the immunization. Okay, like TT injection they can give. So these are the main services will be given by the ICDS. Okay, then RBSK. What is RBSK?
Rashtriya Bal Suraksha Karyakram.
Okay, so what are the main components in RBSK?
In RBSK, we check for if any there are in the child, if there are any deficiencies, if there are any defects, and we check for the developmental status of the child.
So what is that is 4D. They look for the 4Ds.
Sorry, sir?
They look for the 4Ds.
4Ds, yes, sir.
Yeah. So can you repeat again what are the 4Ds?
Yes, sir. It is there are any deficiencies,
and
if there is any defects, and then for the development of the child.
Development delays and diseases. Okay. So they in that RBSK around 30 diseases have been listed.
Yes, sir, 33.
Okay, 30 Ds has been listed, under each, at least for each type, 4 Ds are there. No? For each type, at least you should know two diseases.
Okay, sir.
Okay, and it is almost covered up to 16 years to 18 years, I feel. Okay.
Yes, sir.
Yeah. So then what is Navajata Shishu Karyakram? NSSK?
In Navjata Sishu Karyakram, they ensure that the health professionals, they are like they're trained to like help if there's any complication and if for resuscitation of the child, of the neonate.
Okay. So you have to read about RMNCH plus A program. Okay. So they may ask why they added plus A component and all. Okay. So apart from that, just one question I wanted to ask: what is home-based newborn care?
Sorry, sir. Could you repeat?
Home-based newborn care.
In home-based newborn care, we make there'll be ASHA worker who comes and who checks at the child if it's like fine at regular intervals, and there is there are a number of visits. There are five visits by the ASHA.
Yeah, it's 6 visits. 6 visits.
6 visits.
6 visits in case of normal institution delivery. In case of home delivery, she has to have 7 visits. Okay, and anything else is there in Karnataka, like for female child if it is born? Bhagya Lakshmi scheme. Do you know what is Bhagya Lakshmi scheme?
No, sir. I'll read about it, sir.
Yeah, that if if a female child has been born, government will deposit 20,000 rupees in the account of the child, and it will be given only after 18 years. So it will be like a fixed deposit.
Okay, sir.
Okay. Yeah. So if you have any doubts, you can ask. Otherwise, we will almost done. But you have to read. Okay. So many schemes are there. RMNCH means RMNCH plus A, then RCH1, 2. What are the main difference between RCH1 and 2? Why it has been changed to RMNCH plus A? Then what are the difference between JSY and JSSK? Then why RBSK has come? Okay, you should read all those things. Does iron and folic acid in different trimester? No, it's almost same.
First trimester usually we don't give.
Yeah, iron we don't.
Start from the 14 weeks.
So why don't we give in iron in first trimester, Nisarga? It is not teratogenic.
Because of nausea and vomiting.
It may aggravate the nausea and morning sickness. Okay. So anything else? Any other doubts? If you're having, we can discuss. Okay. Nisarga?
Hello, Nisarga? Hello?
Yeah. So in one minute, somebody has asked a question. In JSSK, newborn is 30 days. 30 days for the admission. Okay. I think Nisarga. Yeah, if everything is okay, we can end the session.
I think her audio is muted, sir. I don't know. I think she's not available.
Okay.
Thank you, sir. Thank you, Thilak, sir, and Abhilash, sir, for all the detailed discussion. Sir, any doubts? We can get back to you, no, sir. Like message on.
Yeah. You can. They can message me. No problem.
Yes.
Okay. Abhilash, thank you, Abhilash.
Thank you, Thilak.
Thank you, sir. Thank you, Nisarga.
Yeah. Bye.
Bye, sir.